He has numerous publications in Nature genetics, seeing that anyone with congenital heart, and currently is working in Spire short-neck heart as a laureate from the University of Edinburgh.
Thanks, Paul. Thanks to everyone. It's a great privilege to be here. It's a really wonderful lecture theatre you have here, which is a real privilege to see. Good to see that you're feasting your microbiomes, or rather poisoning your microbiomes with huge quantities of doughy, cheesy, meaty deliciousness from the pizza boxes. Thank you to the residents. We just had a very, very entertaining. This is very loud. Can you turn me down a bit, please? We'll just turn me down a little bit. We just had a very, very entertaining teaching session with all the residents, so thank you very, very much for that. Chalk and blackboard, talking about several different, there we go, brilliant, perfect. I want to change tack a little bit today, and I want to talk to you about inflammatory bowel disease. I want to talk to you about prediction and some of the work we're doing. I want to perhaps inspire you a little bit about building prospective cohorts, investing the time and energy to collect quality data to help address questions of disease outcomes. Inflammatory bowel disease is getting more and more common around the world. Okay, you would have heard this before, but it is really true. There is no doubt that within the next 5 to 10 years, we are going to see many, many more millions of people around the world diagnosed with IBD. It is already truly a global pandemic. This is the shift that we have seen across the world to the present day, but the future picture is like this. In Scotland, we've been blessed to have rich epidemiological data going back to Anne Ferguson's day from the 1970s, so that we can look and plot what's happened to early onset inflammatory bowel disease. And we can do this from 1970 all the way up through to the present day, and equates to, with early onset inflammatory bowel disease, a 5-fold increase. This is continuing to get more common. We're just completing a very, very detailed prevalence study with Edinburgh at the moment, looking at all the different coding sources of information, looking at GP records, looking at prescribing data, looking at all our CAF records. We don't quite yet know what the number is, because we're painstakingly validating the last of the 10,000 cases that we've identified. But what we do know already is that the prevalence rate is upwards of 1%. It looks to be settling at about 1.1%. And this is matching what you're seeing in these parts of Canada too. So IBD is common, it's getting more common. People stop and ask me about a cure for inflammatory bowel disease, and they ask us to be able to prevent it from happening in the first place. And I'm going to put it to you that this is a big, big challenge, and one that we're currently a million miles away off being able to achieve. And why is this such a problem? Well, to stop someone getting inflammatory bowel disease, we need to take a step back and work out what the biomarkers for a preclinical disease state would be like. Can we identify those people at risk? Can we then intervene to prevent those people at risk from developing disease? And then can we maintain that state? And if we can, great, but how long do we have to do that for? Let's say you find a 4-year-old boy who's at risk of developing Crohn's disease. You've got those biomarkers that tell you he's at risk, and you've worked out that you need to do something to change it. Maybe it's a microbiome manipulation, maybe you're going to give a stool transplant to fix it. But you're going to have to do that every day for the rest of his life, while he's in that environmental exposure. We don't know these questions. It may be much more simple than that, but I think this is complicated. And I think at the moment, we need to invest our time and energy in building the models that will allow us to work out how we're going to do this. So for now, we have people with complicated disease who present already with disease having developed. Like this case, a 30-year-old male who presents with a significant history of postprandial abdominal pain, weight loss, lethargy, malaise, significant fatigue. He's got a robust iron deficiency anemia, he's lost a lot of weight, he's got a robust inflammatory response with a high CRP, a robustly elevated fecal calprotectin. You do a workup, you diagnose terminal ileal Crohn's disease on MRE, he's got at least 50 centimetres of disease affecting multiple segments. And you're already in reactive mode for this patient. You know there is already going to be fibrosis in that small bowel, you're already playing catch up. You're going to try and get him to an optimal state with a treat-to-target paradigm so that you heal the mucosa and you get him free of symptoms, but you're going to be playing catch-up. And even now with our best medication strategy, putting someone onto an anti-TNF and a thiopurine and avoiding steroids, using judicious feeding to help, we're in that kind of catch-up situation. Here's a different situation. This is just to remind us of some of the complexities that we face. Here's a 22-year-old female who presents with colonic Crohn's disease, or Crohn's colitis. And it's not particularly bad, but she's very symptomatic. She's going to the toilet 6 times a day, and you think, oh, that's not too bad. Think about how bad that would be for you, with pain, with blood, and she's tired, she's got a mild anemia, CRP's up, calprotectin's robustly elevated. You diagnose pancreatic Crohn's disease, you give her a course of steroids, and she gets better. She gets better out to, the delta's improving to week 4, by week 8 she gets better, by week 14 she's completely better. And then you continue to monitor over time. For someone like her, for me in that first year, I've been 12 calprotectin symptoms every 2 to 3 months to make sure she's okay. We're going to be bold, we're going to leave her on no maintenance therapy, and that's all right. Because there are people with inflammatory bowel disease who will just have one significant inflammatory burden and then they will be okay. Unfortunately, they are the minority. Most patients will have some form of relapsing remitting disease that over time will cause increasing complications that we're aware of. And this is plotted for Crohn's disease from the Ipsen data, which remains the only real population-based data looking at disease cause and outcomes. So this is the problem, okay? Patients with Crohn's disease and ulcerative colitis will have relapsing remitting disease. We know that. So flares will occur intermittently, and in between times, patients may feel much better. But what's happened traditionally is that we've just treated those flares, we've ignored what's happening in between, and all the while, the disease has evolved, the bowel damage is accumulated, they're getting strictures, they're getting fistulae, abscesses, they're having surgical interventions, and we're failing our patients by being in this reactive mode and not looking deeper under the skin of what's going on with the disease. I'm going to orientate you to this graph now. So a patient is born into their inherited environment with their DNA, the microbiome which settles quite quickly, their environmental factors, and at some point, those patients who are at risk will start to develop a preclinical inflammatory state, and then probably triggers will occur that will lead to the development of IBD at a point where you make a diagnosis. Now, unfortunately, most people are not then just diving into prolonged remission, they're having further flares and the disease is evolving. And we've been hypothesizing for a while now that perhaps the triggering events that lead to flares may be the same as the triggering events that lead to disease development. Now, Paul and others have been very intimately involved with looking at this bit here through the general study in Canada, as many of you will be aware of. And this is such an important effort because what it does is it tries to get around the issue of causality. You have to look at people before something has happened to work out whether or not the changes are the result of the inflammatory state or the drugs, or whether or not the changes are the things that actually drive the disease from developing. So what we've been doing is we've been jumping into this state here, where we can start to access patients in a non-flare state, and then maybe look at, say, what the trigger events for flare are. And the things that we've been concentrating on are looking at the microbiome, the genes, and the environment. The genes is where I come from. My background, a decade of gene discovery experiments, which have been phenomenally successful at starting to tell us about the genetic architecture of Crohn's disease and ulcerative colitis, and of course many other immune-mediated diseases too. They're starting to yield many druggable targets and overlapping with existing therapies. But they're not perhaps telling us very much yet about disease phenotype, about disease progression, about behavior, and about being able to stratify our patients based on their genotype at the onset. The microbiome is a fascinatingly complex area, and it's become very, very difficult for us because of the issue of causality. And so, many of us involved in the international IBD genetics efforts have been able to recruit patients for our studies at any point during their disease course. So we've been able to take someone who's had Crohn's for 30 years, someone who's had ulcerative colitis 40 years ago, had a colectomy, and take a DNA sample, retrospectively phenotype them, put them into the cohorts, and look for susceptibility genes, because the inherited DNA, of course, doesn't change. But you just simply can't do that for the environmental factors, for the microbiome, and you also cannot do that for the environmental factors. We have to study these things when people are well, so you can look forwards. And so we have this full panoply of environmental insults that have at least some evidence for a role in either disease causation or in disease prognosis. Now, actually, many of these things, we don't yet have robust data to support what's going on because we lack the prospective cohorts that allow us to get unbiased information with all the confounding factors appropriately corrected, so that we can start to look at sleep, diet, medications, antibiotics, hygiene, emulsifiers, travel, geography, exercise, surgery, smoking, stress, sunlight and vitamin D in a controlled way. And many of these things actually, you can look into big data sets that already exist from environmental agencies, for example. You can map out where your patients live and sunlight exposure in minute detail over many decades. You can start to use physiological wearables to look at people's exercise and habits. You can track their movements. You can look at prescribing data sets. You can start to understand the pollution in the environment that someone is living in to see what is going on. So that's what's been happening in terms of looking at disease causation, but it's also very important moving forwards. And what we're trying to do is apply these things prospectively so we can look and get under the skin about what's happening with disease flare and disease progression, so that we can then work out how to go back to interventional studies to intervene, so we can then reduce down and stop disease progression in patients with IBD. So this is what I want to move towards, a situation where we're going from top left in reactive mode with disease evolving to getting rid of the disease evolution to perhaps getting to this stage at the bottom where we can completely control someone's disease early on. So I call this scenario IBD no flare. So we get a patient here, they've made a diagnosis, we accurately and robustly stratify their disease by their risk of progression, their risk of complications, and by their disease biology. We then use our most effective drug strategy for that individual. This is starting to look like precision or personalized medicine properly. We robustly and completely induce remission. We keep that state, we maintain remission. We get rid of the flares. And honestly, if we could do that, if we could do this in patients, then that would be utterly transformative. And it would probably be almost as good as curing the disease if we could do that. So this is where we're starting to get to by building the predicted data set of the cohort that we're doing. We're recruiting patients in remission, just in clinical remission, because we want these findings to be generalizable. And we'll do a deep dive with stratification for patients who are in deep remission. We decided to recruit 3,100 patients with IBD, 50-50 Crohn's UC in clinical remission, with a detailed baseline data set that I'll tell you about. We're going to follow them every single month for 2 years. And then at their primary endpoint disease flare, we're going to look again, we'll collect further samples, and then we'll let patients go back into follow-up so that we can look at recurrent flares over time. And the primary objective to do that is to test the associations of disease flare with a variety of dietary factors that come from the existing literature, as well as looking at microbial factors. But we will have a wealth of information to look into more details. So, essentially, we're trying to determine which aspects of baseline individual diet, the environment, genetic variation, although we're not brilliantly powered to do that, the microbiome, predict disease flare and Crohn's disease and ulcerative colitis. To do this, we've aligned with the UK IBD bioresource. This is where we've gone with our genetic studies for IBD in the UK. We have gone back to our existing patients, we're looking for new patients, and we're recruiting them into a recallable bioresource that is recallable by both genotype and by phenotype. And these patients are all getting whole genome sequence by the guys at the center. So we're recruiting 25,000 patients across England and Wales. We will recruit 10,000 from Scotland, giving us 35,000 patients with whole genome sequencing data at least 24x coverage. And then they know this recordable database that will be available for anyone to access from academia and from industry. And what Miles Parks and I have done is we've aligned the data sets with PREDICT, so that with PREDICT we can then layer in some of the prospective follow-up of these patients. And what this includes at baseline is a deep dive into diet, and we're doing this in two ways. The first way is that we're looking at a food frequency questionnaire developed by the Scottish Food Collaborative at the Broward Institute in Aberdeen, where we do this 180-point food frequency questionnaire that patients can do online. We've now layered into that a 4-day weight food diary. How does that work? Well, we give patients a $10 set of scales, digital scales. They zero them with their bowl on or their plate, and then they put on the different elements of their dish, and they weigh them individually, and they write them down in the old school with a pen on the handwritten diary. They do that for everything they eat over 4 days. They post it back in, and then the dietitian assistant phones them up with questions to clarify things, like someone says, I had bread and butter, how many bits of bread did you have, what kind of bread was it? Was it butter, was it margarine, was it high fat, was it low fat? So they can then do a very deep dive into the diet. And what's really exciting about this is that we're asking patients to send their stool samples in on day 4, so we can then compare the 4 previous days of dietary input with the microbiome on day 4. And those stool samples are 3 tubes, 2 with different buffers in, a third one that's non-buffered, and with that third one we can also then measure the calprotectin in our lab in a standardized manner for all patients, so that we have that baseline level of information present. From home, they also then do a series of environmental questionnaires. This is pretty detailed, but it takes them no more than about 1 hour, and they can do it through the app, which I'll come to. This takes into account their phenotype, their medication history, compliance, quality of life, sleep, emotions and mood. We've just added in a Brit resilience questionnaire in collaboration with Mark Dubinsky and Roy Kiefer from Mount Sinai, New York. Stressful life events, weight loss, exercise, travel, alcohol, smoking, etc. All validated questionnaires where we can, not necessarily validated in IBD, but I don't think that matters for the purposes of what we're doing here. And then the samples come in remotely. So the way it works is very scalable and it's very portable. So patients sign up, they take 20 minutes with the research nurse, they go away with their pack, and then they can do all their sampling and their phenotyping from home. The samples come in via post with saliva for whole genome sequencing and the stool sample that I told you about. And with that, we're following patients to the point of disease flare. So, very simple inclusion criteria. Patient with Crohn's disease and ulcerative colitis, they have to have had diagnosis 6 months ago or more, and they have to not have had a new treatment in the last 2 months, no steroids in the last 2 months, no surgery in the last 2 months. So we're just over 1,000 patients in, 1,021 at the last count 2 weeks ago, and we're getting up to 3,000 by hopefully late spring next year. We've been looking very carefully about how we collect the data, and I wanted to spend a couple of minutes just telling you about the way that we've evolved to do that now. We've got an amendment going through the efforts at the moment that's going to transform our current system to this, which is, as we're doing at the moment, an EMR extract manually into the PREDICT database, as you would do for many studies. But patients are going to start using the OSHI app, which I'll tell you a little bit more about, to input their information in. So patients input their PRO data, they input all their questionnaires into the app. This then feeds back, of course, to the PREDICT database that feeds information back to them, and then we're piping all of this information down to the bioresource, as well as ultimately down to the UK registry. So what is OSHI? Well, OSHI is a company based in New York that is setting up a symptom tracking device for people with IBD. Lots of people are doing that, but this is a really detailed, thoughtful way of doing it, so that you can combine mobile with activity with real-world data and personalized therapies ultimately. So it's a symptom tracking device. It's a device that learns people's habits, so you can then hyper-personalize information with a lot of original content built in. But for PREDICT, what we are doing is we have developed, in collaboration with the OSHI team, what I think now is the world-leading mobile data collection tool for people with Crohn's disease and ulcerative colitis, that will also allow us to then combine with the symptom tracking system and then hyper-personalize and feedback content to patients over time, such that they'll get back information about their depression and anxiety scores, with signposting if they score badly to need help, so that we can take people who've got poor grit and resilience scores early on, and the bottom 10% can maybe go on to do some CBT online. The bottom 1% you can then maybe target as the most vulnerable with teachable skills by your psychologist, your clinical psychologist, which certainly for us is such a very precious resource. So we have all the questionnaires now built into a truly mobile application with the monthly questionnaires, the completion scene, patients can get prompted. We can move towards a truly digital study. At the moment we're completely paper-free. By next year what we will offer people the ability to do is download the app and then digitally consent to the study. So almost anywhere in the world they can take part. And then all the data comes through to the portal. What's very exciting to me is that when we do this, it does it independently of the EMR. We do that one-time extract that gives that baseline phenotyping that is clinical grade done by the hospitals. The patients give all their information, but we give patients back a curated real-time summary of where they're at. So it includes some static fields. So Joe Bloggs, age 30, Crohn's disease diagnosed age 20, it affects the small bowel, had surgery 3 years ago, I've had these medicines during this time period, these ones worked, these ones didn't, this one gave me toxicity, these are the current medications, here's my symptom tracking, and here's my disease activity over time. And that can be very, very powerful to that HCP patient interaction wherever it is, be it in the emergency room at 3 a.m. where the emergency physician knows nothing about them, or be it in the routine outpatient clinic. And that will certainly be transformative for the way we operate in the United Kingdom. Okay, I'm going to change tack a little bit now, just to talk a bit more about some of the different aspects of prediction and how we can help to model patients and how we can help to improve outcomes. Bear in mind that, as I said to you before, most patients are going to be in this relapsing remission state. What we would ideally like is to have people in prolonged remission, which means a normal quality of life, a completely healed mucosa, no bowel damage, and no toxicity from our drugs. Thank you very much indeed. To do this, what we need to do is we need to be much more savvy at diagnosis to stratify our patients by both risk and by biology. And I feel at the moment that as a clinical research community we have failed the IBD world by not getting better at doing this today, such that we're not yet able to work out beyond the Beaujeu criteria, which are the genetic and microbial risks for disease progression, nor are we able to work out in a sensible way which drugs to use when for which patient. We have to flip a coin and say, okay, you can have thiopurine, you can have steroids, you can have an anti-TNF, you can have monotherapy, you can have chemotherapy, you can have JAK inhibitor, you know, etc. We're going on and on and on. And this is a problem, particularly if we bear in mind that patients who fail anti-TNF in Crohn's disease only have approximately a 10% chance of having mucosal healing with their next biologic at a year. And we don't know yet whether or not that's some kind of immunoconformational shift that is occurring because of the TNF treatments that actually means they're much more refractory, or whether or not this is just a more refractory group of patients. And the research world still doesn't know the answer to that question. It's one of the key unanswered questions in IBD to date. So for now, we're doing the best job we can with the information that's available. I mean, yes, I'm being a bit down on this, and yes, we do have things that we can do. We can look at the various aspects of risk. We can do the very best that we can to make the right judgment call for patients for the first time. And then what we can do is we can do the thing that we've got very good at over the last 5 years, which is monitoring, adjusting our treatment based on the results of monitoring, and optimizing to improve outcomes. And that's the sort of treat to target model that we have been using over the last few years. Now, my old slide for treating Crohn's disease looked like this. Mild disease, maybe a one-off course of steroids, more severe disease, probably going straight into combination therapy, and then this big bucket of patients in the middle with moderate disease. And actually, we know that the inflammatory burden at diagnosis is not the thing that predicts outcome. Right? We can have 2 people with colonic Crohn's disease, both with a CRP of 100 diagnosis, who can have completely different responses to treatment disease courses. It's the risk factors and other unknown elements that are responsible. But nonetheless, with what we have at the moment, I'm still looking to stratify these patients based on their risk to either go onto a more top-down based approach or to go into more of a step-up approach. And then we're monitoring along the way, no matter what we've done, to get us there. I do wonder in future whether or not we're going to start already, perhaps in many places, to replace those fire-curing monotherapy patients with an anti-TNF therapy, or perhaps another strategy like an anti-insulin. But because of our poor predictive ability, we are very reliant on type monitoring. So here are those risk factors for disease progression, those Moayyedi risk factors that we've known about for well over 20 years now. Some of them are helpful. Extensive small bowel disease, perianal disease, significant weight loss, deep ulcers at endoscopy that predicts colectomy at a year. Others, I think, less so. Young age smoking, steroids diagnosis. Well, I think it's okay for some people to have a one course of steroids, like that case I showed you earlier, and then we move to a different treatment line. But I do think we need to be more savvy about this, and the way that we're going to make a big difference is by using big data sets with multiple inputs, and then to be able to clinically and molecularly phenotype our patients, both those that have a bad course and those that have prolonged deep remission, and then use machine learning and AI to help hyper-personalized care for people with IBD. And then when we look at our treatment buckets, what I hope that we'll be able to do is actually take this as a whole and start to give people the drug that's actually going to treat their underlying disease biology rather than doing it in a way that hasn't worked so far. One of the efforts to try and help this is the PANT study that my friend Tarek Ahmed and his colleagues next to have led, and this has been a very successful collaborative research project across the United Kingdom, setting out as a primary hypothesis to see whether or not patients treated with anti-TNF have the respond versus those that don't respond have genetic risk factors that are associated with primary non-response. So with the primary aim of primary non-response to anti-TNF therapy at week 14, looking for genetic risk factors. So Tarek and colleagues set up this big experiment, ultimately recruiting nearly 1,000 patients with infliximab, 650 with adalimumab, treated and followed prospectively over at least a year. I won't go into the definitions of response and non-response too much here just now. Now, what we did in this experiment was trying to find genetic factors that predicted primary non-response. And what we found was nothing. Absolutely nothing at all. The Manhattan plot was as flat as you like. It was as far removed from the Manhattan skyline as you could possibly want. It looked like, a desert. But when we then used the genetic machinery to look and see whether or not we could predict immunogenicity, we found a very strong hit. And here you are on chromosome 6, a signal that's localized to the HLA region, and specifically to this allele, the HLA DQ8105, which explains the risk, that has a ratio of 1.6, and a very strong significance subsequently replicated. And this is clinically useful, and this is important. What you're looking at here is the time to development of immunogenicity, so antibodies, to infliximab. Okay, sensitive patients at the start, no one has antibodies to infliximab after days, you can see. And this is the plot for patients who don't carry this risk allele and who are on combination therapy. And you can see the development of antibodies over time. This is if you don't have the risk allele and you're on monotherapy. So we know that, right? If you're on monotherapy, rather than chemotherapy, you're more likely to get antibodies to infliximab. You see that very, very clearly here. Now, what about if you have this risk allele, but you're on combo therapy? Actually, you do almost as badly as the people that are on monotherapy. And then what about the people who have the risk allele and are on monotherapy? And you can look at that. They do terribly. They almost universally